Hello everyone.
Hello, sir.
Hello, how are you doing all?
Great.
Okay,
How are you, sir?
I'm good, thanks for asking. How about your studies?
It is going on, sir. It is much easier than the earlier times. Thank you. Thank you for the team too.
Thank you so much. And do you guys have revised the previous module, polymer module?
Yes, sir.
All right. So actually today class will be most of a revision class. So all of you should participate. Okay. So we will be doing MCQ together. Okay. And most of the part you guys will be doing it, okay? Okay, so is my screen visible?
Yes,
Yes.
sir, it's visible.
So you will be doing it together,
Bir dakika
okay?
bekle. Bir dakika
You,
bölüm. Bir dakika
you guys will be participating more, okay?
bekle.
Inshallah, sir.
Because today most of the options they will be giving are already discussed with you, okay guys?
Okay.
Okay.
So I think we should start, right? Because
Yes.
it's already late.
Okay.
Yeah, but we don't see the question, honey. We don't see the. Oh, okay, it's coming up right now. Bir dakika, bir
Okay.
dakika bekle. Bekle, bir dakika bekle. Bekle.
Yeah. Anyone, please?
Yeah.
I can.
Hello.
So
If this patient were to be diagnosed with renal
Yeah, what
disease,
tax is this, please? What tax is this?
Sorry.
What tax number is this, please? Excuse me.
Sorry, I didn't get you.
Yeah, what tax number is this? What number on the renal structure? What tax number is this?
He's asking the session number. Session. I
Okay,
can read
so
it.
it's 6th day. Tomorrow will be the last day of renal module, and we will be starting gastro, okay, after that.
yeah.
Okay, that's good.
Okay, anyone, please.
If this patient were to be diagnosed with renal disease later in life, it would be most likely which of the following? A newborn undergoes an abdominal ultrasound that shows kidneys of small size, normal
Sorry.
structure, and location.
Yeah, please.
So the patient does not appear to be distressed, and physical examination reveals no abnormalities. So patient would be diagnosed with renal disease later in life, the most likely would be the following. So
Okay, so
that's clear. That will be dominant polycystic renal disease that appears later in life. You told us before.
yeah, great.
Person's old age. Yeah.
Yeah, so today most of the questions we have already done, and I will try. So anyone new here? Any student who is new to the class?
Yes, I'm new.
So it's first day.
Yes.
Okay, so we will be trying to cover the concepts. Okay, so what do we have in our STEM? That a newborn is undergoes an abdominal ultrasound. Abdominal ultrasound shows normal size structure and location of the kidney. So what does it means? Normal size. They are asking about the, if we look into the options, autosomal dominant, autosomal recessive, horseshoe, and multicystic and Potter's. Okay, so we will be focusing on these diseases. Okay, so the patient does not appear to be in stress, and physical examinations reveals no abnormalities. If the patient were to be diagnosed with renal disease later in life, it would most likely to be which of the following. So I think all of you got the question. It's very easy, but let's do it. So we have normal kidney at birth, right?
Yeah.
Yeah.
So in autosomal recessive and multicystic kidney disease and Potter sequence and horseshoe kidney, it won't be normal, right? Except
Right.
autosomal dominant, which will be presenting later in life. Okay.
Yeah.
The other thing is that autosomal dominant have these small cysts, but they are very small, that are even undetected by ultrasound. Okay, that's why they are saying kidney is normal. The patient does not appear to be in distress, so we can exclude from here the Potter sequence, right? He has no distress. Okay, no signs and symptoms of shortness of breath or respiratory distress, etc. Okay.
Yeah.
Physical examinations reveals no abnormalities if you were to diagnose later in life. So it will be autosomal dominant. Okay. So I would like to discuss the cystic diseases very briefly. Okay. So you will be doing all other MCQs very easily. Okay. So we
Okay.
have four cystic diseases, right? Number one, multi-cystic dysplastic kidney. Okay. So let's discuss this first. So what do we have in multicystic, which are high yield? Anyone, please? We have cyst, right? It's, but the important thing over here is that we have or very little or no functioning tissue. Okay. Okay. This is important in high yield. Okay. And also we have absence, or we can say absent ureter, and can be detected by ultrasound in utero. Okay, got this? The other high yield point is it can be
Yes.
unilateral and bilateral. Okay,
So you
and
were
it will
telling this about what? Displace?
multicystic
Okay.
dysplastic kidney.
Okay.
Okay,
Okay, yes.
multicystic
Displastics.
dysplastic.
Differentiate. Inconsistent.
Okay, should I revise it?
No, sir, it's fine.
Okay, so it can be unilateral and bilateral. Okay, when it's bilateral, we have no functioning tissue or very little, so it will cause Potter's. Okay, got this? And it's non-hereditary. Okay, so other than doing each separately, I would like to go on with discussing each simultaneously so that you can multicystic. Okay,
Okay.
this plastic kidney. The
Mm-hmm.
second one we can discuss, that is autosomal recessive. Third, autosomal dominant, and last one is medullary cystic. Okay, so this can be unilateral or bilateral, but most of the time it's unilateral. Okay, autosomal recessive, it's bilateral, Autosomal dominant, it's also bilateral. Okay.
Okay.
And multicystic, also bilateral. Okay.
Okay, sir.
What other important point over here is that okay, that we have what we have over here, size will be large, right? We have
Yeah, hydronephrosis.
cyst
Yeah.
because of cyst also. Okay.
Yeah.
Okay.
And medullary cystic kidney is smaller. Okay.
Any particular reason, sir, why it's smaller in the medullary cystic?
Yeah, so the let me discuss it. Okay.
Okay.
Excuse me, sir. What is this number one? What you wrote? This number one?
Okay, sorry.
Multicystic dysplastic kidney.
So we have
Okay.
4 diseases. Okay. The first one is multicystic dysplastic. Okay.
Okay.
Multicystic dysplastic. Okay.
Okay.
Kidney. Okay.
Mm.
This is the first one. Okay. So we have very little functioning tissue here. Okay.
Okay.
Functioning tissue. Okay. Most
Okay.
are very little or even no tissue. Okay. Most of the time it is unilateral. Okay. And
Okay.
can be easily detected by ultrasound. Okay. The only one that is not detected is autosomal dominant. Okay.
Yeah.
Got
सर
this?
इसको कहीं
If
ज्यादा
this
चेंज करते हैं
if this condition is bilateral, it can lead to Potter's. Okay.
मुझे लगा कि बस एक एंजाइटी का टैबलेट दे के कहानी खत्म
Sir,
अब तो
autosomal
वॉमिटिंग हो जाए
polycystic kidney disease cannot be seen on. That is what you're saying.
Yeah, what I am saying here is autosomal recessive is the condition of children's, right?
Yeah.
And this is adults.
Yeah.
So what happening over here is, or it also in a question, right? That if we look into the kidneys later in life, so what we will see. So the point over here is that the autosomal dominant, we have cyst in kidneys.
But it's
Okay, but
visualized later.
it's very small. Okay,
Okay, okay.
very small. Okay, and it is almost at 40 years or 50 years the disease is prominent. Okay, so what about autosomal recessive?
That is manifested early in life and with
Yeah,
Potter sequence and pulmonary hypoplasia.
yeah, great. So the autosomal recessive is early or childhood. Okay, can lead to Potter's, bilateral. Okay, because it is congenital, right? So affecting both kidneys. Chromosomal abnormality is affecting both kidneys. Okay, and it is associated with, this is important, you guys should know, liver disease. Okay, liver cyst and fibrosis. Okay,
Hypocyst.
and the autosomal dominant is associated with,
Aneurysm, perianeurysm
yeah,
rupture.
so we have liver cyst and aneurysms. Okay, yeah, so I think these are the high yield points about these kidneys. We will discuss it more with the coming MCQs. Okay, so what about horseshoe kidney? So we will easily see it through ultrasound. Okay, fusions, right? Fusion of inferior folds. Okay, got this? It can be seen by ultrasound in newborns. Okay, and here in the questions they say does not appear. Same for multicystic and Potters. Okay, and in case of Potters they will have respiratory distress. Got this, guys?
Yes,
Sir.
doctor.
Yes,
Very
sir.
clear.
Yeah, anyone please?
Okay, so physical examination shows no abnormality, pardon. The CT scan of the abdomen with contrast is shown below. So this is okay. Okay, let's see. 54 years old man comes to the physician due to blood in his urine and abdominal discomfort that occurred 2 days ago. He was moving a potted plant around the porch when he started having pain on in his abdomen. Afterward, he noticed blood in his urine, but says it resolved. Oh,
Sorry,
hello.
sorry. Give me a second. Sorry.
Uh,
I'm sorry. Okay.
um, Hold on. It resolved the following day. He has history of hypertension. Patient doesn't use tobacco, alcohol, or illicit drugs. Physical examination shows no abnormalities. So this is a hold on. We have to
What's the
find like
question asking?
which of the following is the most likely diagnosis, right?
Yeah.
Uh, this is the
So,
age there and the smoking,
yeah.
uh, abdominal pain, uh, and then
So
plant
we
and
have,
So there's cysts in the kidney.
yeah, great. So we have
Renal cell
54-year-old.
carcinoma. Renal cell carcinoma.
Okay. So we have 54-year-old man with abdominal discomfort 2 days ago. He was mowing potted plants, etc., having pain. After he notices blood in the urine, but he says it resolves the following day. He has history of hypertension, does not use tobacco, illicit drugs. Physical examination shows no abnormalities, but CT scan shows the following. So what do you see in CT? First, they are kidneys,
uh,
right? So we
And
have
also
Yes.
there are
cyst in the liver.
we
so
have
there are two kidneys, right?
cystic kidneys, cyst in kidneys, right? Multiple cysts,
Yeah.
right? This is stomach. This is liver, right? So what do you see in liver? Cyst
Cyst.
also.
That's a cyst too.
So this is autosomal dominant.
Yeah, and the
Polycystic
age
kidney
is
disease.
54.
54.
54.
Okay, so
Okay.
you will get it when you see into the other options, and when we do more MCQs, you will see how the other like renal carcinoma looks like. Okay,
Okay, so
so it is
so
for
it's
the
the polycystic kidney
cystic
disease.
kidney disease. Okay, what about nephroblastoma?
That's in children, right?
Yeah, we
More in
call it
yeah.
Children.
Wilms tumor.
Those
The
tumor, yeah.
common age is 2 to 4 years,
4.
right?
Yeah.
And we will have a whole solid like mass. Okay,
Yeah.
Yeah.
so what we have discussed, I would like to revise because I think today class is more of a revision class, so you guys should have some revision. Okay,
Yes,
so
sir.
we have autosomal dominant. Okay,
Okay.
if you guys are more interested, I think it's chromosome 16 and it's chromosome 4. Okay,
Yeah.
yeah, we have plain pain, hypertension, hematuria, and progressive renal failure. We discussed that, right? Multiple cyst, renal cyst. Okay,
Okay, sir.
and we have discussed this that we will have
Okay.
cyst and cerebral aneurysms. Okay, so these are very high yield points. They may come in coming questions. Okay, so
So, since
yeah,
there are multiple cysts, can the kidneys appear enlarged? I feel it's
yeah, they
enlarged.
are enlarged. If you look into the kidneys, they are
Yeah.
looking pretty enlarged, right?
Yes. So
So
there is an element of hydronephrosis, is it?
yeah,
Can we say that?
it's not because of the fluid that is
Yeah.
causing the enlargement. Okay, we
Yeah.
call
Just
it
a cyst,
when
right?
yeah. So this it is cystic enlargement. Okay,
Okay.
and that's why when we examine the patient, we see that the kidneys are easily palpable. Okay,
Okay, sir.
So how do the hydronephrosis will look like? Now you can see it, okay?
Okay.
Now if you look closely to this picture, do you guys appreciate it? The
Yes,
Yes,
pelvis is
sir.
the
Yes.
pelvis is very
that's it.
enlarged, okay?
Very large and large. Yeah.
Okay.
Oh, wow. Yeah.
Now if you guys look into the nephroblastoma, Willem's tumor, it will look like this, okay? The right picture, okay?
Very big mass, right?
Yeah, it will be a solid
Mass.
heterogeneous mass, okay?
Mass.
So let's move on. So it's also a previous question. Anyone?
Which of the following is most likely diagnosis? A 34-year-old man is brought to the emergency with new onset confusion and lethargy. Lab shows include arterial blood gas are obtained. The changes in blood gas parameters are shown in the graph below. Point A represents these parameters at the patient's physiologic baseline, and point B indicates his state or arrival on the emergency department. So, what's the diagnosis? So, what
So,
does it show that point B serum bicarb
so
is
what is point A? They are saying
less pH, less.
that the point A is normal, right?
Yeah.
It is what they said, right?
Yes.
So and point B indicates his state on arrival, okay? So I think we should not be discussing this, but let's discuss it somehow. This is normal, right?
Yes, sir.
So how much the PaCO2 will be? It normal.
40.
And how much will be the bicarb? This is
24.
bicarb, right?
24.
Yeah,
24.
24.
So what
7.
do you think is happening here?
Metabolic
Yes.
alkalosis, right? It's not
The first
pH
thing
is
I have told you is
decreased. pH is
Acidosis.
decreased. Acidosis.
I'm sorry,
Acidosis.
but the thing you should be doing is the first thing you should be doing is what? Looking into
Normal.
pH, right?
Yeah.
We have made a graph for ourselves that is now become easy, right? We have put it the
Yeah.
normal values. But the first thing in acid base, I have told you that you should look into the pH, right? And
Yes,
pH
sir.
normal here, so it is
7.3 to 7.
decreased, right?
Yeah.
So it is decreased over here. So it is
Acid.
Acidosis.
some type of acidosis, right?
Yes.
Now, what is happening to the bicarb in
Decreased.
PaCO2?
Bicarb is decreased.
Decreased
It
to
is also
bicarb.
Bicarb is decreased. Bicarb is base. If it is decreased, and so if it is decreased, base is decreasing, it can cause
metabolic acidosis.
acidosis, right?
Metabolic
But what
acidosis.
about carbon dioxide? Carbon dioxide is decreased,
Decrease
right?
also.
It
Decreased.
is acid. It should
Yeah.
be increasing to cause
Capacity.
this,
Decreased.
right? So it is not the
Yeah.
cause of the problem, okay? So we have easy, right?
Metabolic acidosis.
Yeah, sir.
Correct. Yeah.
Now
Sir,
again,
I have a
this,
question. I
yeah,
have a
please.
question. So, how did you figure out the values? Like, how did you make that graph to find
Yeah,
the like what is
yeah,
increasing or decreasing? Can you please
Normal
explain?
value. They are
yeah,
normal
okay,
value.
okay. Yeah, they are saying that point A is normal, okay,
Okay.
right?
Yes.
And they have given us on x-axis pH here bicarb and here PaCO2, okay?
Okay.
So point A normal means pH over here is normal, PaCO2 over here, if we plotted it like this, right?
Okay. Yes.
And pH over here is normal, and bicarb over here is normal. So what's the normal value? 40. Tell me. 24,
Yes. 40. Yes.
7.35 to 7.45.
24.
Okay.
Yes.
So whenever we do some studies on graph, we have to make it easy for ourselves. Okay. So again the
Okay.
same
Got it.
question. Again the same
Yes.
question. We have metabolic
Acidosis.
acidosis. Okay.
Thank you
Now,
so much, sir.
okay.
Yeah.
Now what are they asking? Results of the laboratory test shows an increased anion gap. So the second point they have given us that the acidosis is increased anion gap acidosis, right?
Yes.
So we have discussed the normal anion gap and increased anion gap acidosis, okay?
Yeah.
What other thing, if anyone could read it, what other thing they have mentioned? Yeah, anyone please? I want you guys to read it, okay? I'm not going it through like you shouldn't have even read the stem, okay?
The
Sorry,
laboratory
what's your
tests
question?
show
What's your question?
I'm
Do you want us
saying
to read it?
there is
I'm
a drop
saying
in
that okay, that I'm giving you time so that you can read the questions by yourself, okay?
yeah.
Okay.
So
So we are not
the other
going
thing that I saw, doctor,
yeah.
the potassium level is dropped
Yeah, so
with
an
decrease
underlying
of
cause of the we can go it like this,
yeah.
okay? Sorry. An underlying cause is established, an appropriate treatment is started, okay? Within hours, the patient status improve. Repeat laboratory studies shows increase by carb, okay? Sodium levels, decreased serum osmolarity, and drop in serum potassium level. So tell me, what is the normal treatment of acidosis, metabolic acidosis? What do we normally give in DKA?
You give the normal
Give
saline.
normal
Insulin,
insulin.
insulin and normal saline.
GKA and normal saline,
Bicarb.
okay?
Saline, yeah. That's
All
why
right.
drop in the potassium. Yeah.
How we can say it's a DKA? So they have given us some hints, like it's
Increase
anion gap,
metabolic.
anion gap metabolic acidosis, okay? And
Yeah.
from laboratory repeat, we can say that the levels were opposite, right? That the
Even by carb.
potassium were high. We can say the osmolarity was it is decreased, so we can assume, okay?
So it's gonna be A, question A, right?
Yeah, so it is insulin and normal saline, okay? Normal saline. So how does the insulin how does the insulin work? Anyone? What does
Um,
insulin do and how does
By
Insulin takes in the
by
glucose.
potassium, by
Yeah.
taking in the potassium
yeah, so first thing is potassium goes
Pushed into the
into
cell.
influx, yeah,
cells,
intracellular.
okay?
Yeah.
Got this? And the other thing is when we have when do we have diabetic ketoacidosis? In type 1 diabetes, right?
Yes, sir.
We don't have insulin, okay? So body is using lipids rather than carbs for metabolism. That's why we have ketones formation, right? That's the normal physiology, okay? Got this?
Yes.
So when
Yes,
we
sir.
provide insulin, we are providing carbs, okay, to cells, okay? First, we don't have insulin, so we don't have carbohydrates. Metabolism, we have mainly lipid metabolism, right? So this way we can decrease ketones, okay?
Um,
Got this? In
yes.
case of acidosis, the other point is in case of acidosis, when we have increased hydrogen ions, so what does cell do? The hydrogen goes inside and potassium leaks out. Okay, that's the normal acidosis phenomenon. Okay, by insulin, we put
Put
potassium
back.
back. Okay, got this?
Yes.
So if anyone just know what how do we treat DKA? So it's a simple question. Okay, now you can see what is happening here. lack of insulin. Okay, so we are producing more ketones. Okay, and ketones are acids. Okay, and I have told you when we are take when any acid is increased, that's going to replace bicarb, and we will have increased anion gap acidosis. Okay, and we have extracellular potassium shift. Okay, and the other important thing is hyperglycemia can lead to osmotic diuresis. Okay, the glucose that are going out from the body will take water and salts. Okay, so we have hypovolemia and yeah, anyone, guys, you are understanding it or not?
Yes.
Yes, and potassium depletion. As there's water going, there's
Yeah,
potassium
so
depletion also.
More water diuresis and more excretion of the minerals. So
yeah, so overall, the important point about potassium is that the potassium in our body, total potassium in our body is decreased, okay? But in serum, the potassium is raised, okay? Because of leakage of potassium and influx of hydrogen, okay? This is the normal phenomenon that the total potassium of the body is decreased, okay? That's why they are saying potassium depletion, but hyperkalemia, okay? Got this point?
So can you tell it one more time, please?
Yeah,
It's just like,
I am saying I am saying that the hyperglycemia towards osmotic diuresis, okay,
okay,
and it leads to loss of water and sodium and potassium, okay. So
okay,
the total potassium in our body is decreased, okay,
okay,
but it most of the potassium are inside the cells, okay, so we are leaking potassium constantly. Some are going out in urine, okay, but
yeah,
we also have increased potassium in blood, okay.
yeah,
The loss of potassium in urine is not making the potassium level normal, okay.
okay,
The other important point over here that we are losing sodium, right, in osmotic diuresis, okay.
yeah,
We are losing sodium, but we says that we have hyperosmolar. Yeah, we have increased osmolarity. How is this happening? Anyone? If we have decreased sodium, we should be saying that the osmolarity is getting decreased, right?
Because of potassium, it's leaking continuously.
So if potassium is leaking, so will it cause hyperosmolarity? No.
the RAS is activating its like
Yeah, we
making.
have glucose, and the high level of glucose is causing hyperosmolarity. Okay.
Is this
yeah,
serum hyperosmolarity?
Yeah.
Okay.
So don't confuse these things that we have decreased, we are losing sodium, okay? We are losing potassium, but we have hyperosmolarity and we have increased potassium, okay? Now you can see the question again that after repeat laboratory, this second last line, okay, sorry. After repeat laboratory studies shows an increase in serum bicarbonate and sodium levels, okay?
okay,
So we are reabsorbing sodium, okay, because first we were losing it in osmotic diuresis, okay. A decrease in serum osmolarity. Why it is decreasing? The main problem or the main cause of the increased osmolarity was glucose. Now glucose is going into the cell, okay.
no,
Got this?
yes, yeah,
And a drop in serum potassium level, okay. So
okay.
all these are the
That's after,
functions of, sorry,
that's after insulin injection, right?
yeah, so all because of insulin injections.
Brilliant.
Okay.
Okay. Thank you, sir.
Now, if we have any point that is missing, Selena Love, I think we have cleared it. Okay.
Okay.
Yeah, anyone, please? What's the problem with the internet? Yeah, please.
I can go.
Yeah,
Um,
please.
Compared to baseline, which of the following sets of serum electrolyte concentration abnormalities are most likely present in this patient? A 35-year-old pregnant woman at 8 weeks gestation comes to the emergency department due to persistent nausea and vomiting. The patient has had intermittent nausea for the past week and vomiting for the past 3 days. Now she is unable to tolerate solids or liquids. Temperature is 36.7 degrees Celsius, blood pressure 90 over 64, pulse is 108, respiration is 14. Mucous membrane are dry and capillary refill time is delayed. Cardiac examination shows sinus tachycardia and no murmurs. The abdomen is non-tender and non-distended. Compared to her baseline, which of the following sets of serum electrolyte concentration abnormalities are most likely present in this patient? So the
So,
patient is kind of dehydration shock.
yeah. So, what is happening to the patient? He is vomiting, right?
He's having metabolic alkalosis.
Yeah, great. So, we have, because of nausea and vomiting, what is happening? We are losing what?
Bicarb.
HCl, right?
Bicarbonate. Yes, sir.
So, we are losing acids, okay, in form
I
of
think
hydrogen ion, okay?
yes, sir.
And the second thing is, what do we see? Patient with intermittent nausea or the past 3 days. Now she is unable to tolerate solids and liquids. Blood pressure is low. Respiration is normal. Mucous membranes are dry, okay?
Dry. Yeah.
So we have
Dehydration.
Dehydration.
volume,
Dehydration.
Severe dehydration.
depletion, or dehydration, okay?
Yeah.
The abdomen is non-tender compared to our baseline, which is the following serum electrolyte concentration abnormalities would most likely be present in this patient. So we have what? Metabolic alkalosis, right?
Yes, yes, sir.
If you guys do not know the whole pathophysiology of metabolic alkalosis, how the diarrhea or sorry, the vomiting causes metabolic alkalosis, just remember that we are losing acids, okay?
Mm, I see.
So,
That's easy, sir.
and so now what we will have? Increase
Bicarbonate.
bicarbonate, right?
Yeah.
And what about the others?
Chloride is decreased.
Yeah, we
Um,
are losing chloride.
Chloride.
Great.
Yeah. And
What about sodium and potassium?
sodium. Sodium. Since the patient is dehydrated,
Yeah,
uh, it should activate RAS, right?
great. Yeah,
So then it should be increased. But
not
are they asking
necessarily.
about the that state or the state before that? Like at this current state, then
Yeah,
since she's dehydrated, then it should be
what's
low.
the current state? Right.
Okay, then
So
it's low.
sodium is
Sodium is
low, right?
low. Yeah. So if sodium is low, then potassium should be
Anyone, please?
high.
Potassium should be
Um,
low also. I think it's
Yeah, it should be low, I think,
also low
So
because of
I
the
will,
aldosterone.
okay, I will make it simple for you that we call this condition hypokalemic, hypochloremic, sorry, hypochloremic metabolic alkalosis, okay?
and then potassium should be low also.
Okay, so let's discuss what is happening overall, okay?
Okay. But just questions, sir. So usually
Okay.
uh, sodium and potassium kind of go in opposite directions, right? Like If sodium
Yeah.
is low, potassium is high, vice versa.
Okay. So let's discuss the whole scenario, what is happening over here, okay?
Okay.
So the first thing is we are losing hydrogen ion, okay? That is in the form of HCl, right? So it initiates the alkalosis, okay? Got this?
Yes, sir.
We have severe vomiting, right?
Yeah.
So leads to volume depletion and RAS activation, okay?
Yeah.
So what does RAS do?
It actually
Stimulate aldosterone, right?
Yeah.
And what's the effect of aldosterone?
sodium water
Increases water reabsorption.
Increases sodium reabsorption,
Sodium and water.
right? And
Yeah.
excrete potassium and hydrogen excretion, okay?
Yeah.
That's the normal phenomenon, okay? Now if we
Yeah.
have increased potassium and hydrogen loss, hydrogen from here, potassium from kidneys, right? So it
Mm.
is increasing or worsening alkalosis, okay?
Mm.
First we have loss of HCl, and now we have loss of hydrogen because of RAS activation, okay? Got this?
Yes, sir.
Yeah.
And
Sir, can you please repeat this point?
okay, so the first thing happening here is that we are losing HCl, okay? The second thing is due to severe vomiting, we are volume depleted, right? Got this?
Yes.
The volume is being decreased, okay? So due to loss of hydrogen ion, we have alkalosis, okay? And also the RAS is activated. RAS is doing what? It is increasing the loss of hydrogen and potassium ions, okay? Got this? But why sodium is decreased? Because the sodium present in our body, or we can say the kidney compensation, is not that much because we have lost so much sodium, and this will be recovered by intake of sodium, okay? Got this? Got this or
Yes,
not?
yes. Yeah, we need to give from outside. The body is not able
Yeah,
to
because
compensate
we
by
have
itself.
severe vomiting and volume loss, okay? And what about chloride? The chloride is losing with HCl, okay?
Hydrogen. Mm.
So we have the option A. So the patient severe vomiting, let's discuss it if someone did not understand with severe vomiting, lead call hyperemesis gravidum, volume depletion, okay? Vomiting causes loss of gastric ions, which lead to increase in bicarbonate, okay? This is the, we can say that the loss of hydrogen ion is compensated by increase in bicarbonate, okay? The other thing is the loss of water in salts, relatively. Yeah, I don't think we need that much of the details. There is a loss of water in salts, right? Leading to volume depletion that increases or perpetuates the metabolic alkalosis, okay? So two things are happening here. The first thing is we are losing HCl with vomiting, okay? And the second thing is that the RAS is doing what? It is trying to reabsorb sodium, okay? And will lead to removal of or excretion of hydrogen and potassium, okay?
It's the sodium loss I don't get too well. Yeah.
Yeah, we will see if they have explained it.
Mhm.
Aldosterone stimulates sodium reabsorption and a lesser degree the relative greater loss of sodium. So
Maybe it's just like
yeah,
the sodium
they
got dissolved,
yeah
so it's
yeah.
not
So
that increased.
so so what is happening over here normally is that we are losing sodium, okay, and other ions with vomiting, right? This is the first point. We are losing sodium and chlorides, okay?
Chloride. Yeah.
But
Oh yes, oh yes.
why the kidney compensation is uh, not recovering the sodium?
It's too
I
low.
think that's the confusion, right?
Yeah.
But due to severe vomiting, we after the infusion of normasaline or after somehow the intake of sodium, we can recover it. But normal kidney cannot recover that much of sodium, okay? Just by RAS, okay? Got this?
Okay, yeah. Okay.
Anyone, please?
This patient's metastatic disease most likely originated from which of the following organs? A
Hmm.
63-year-old man comes to the emergency department due to fever and loss of appetite. He also has chest pain with deep breaths. The patient has never had regular medical care and his medical history is unknown. He has smoked half a pack of cigarettes daily for 30 years. Laboratory evaluation shows a hematocrit of 56. Chest imaging shows multiple round lesions in both lungs. Biopsy of one of the lesions reveals the microscopic findings shown below.
Okay. So the patient metastatic disease most likely. So they have given you a 63-year-old with fever and loss of appetite, okay?
Yeah.
And the
Alpha
most
192.
so important things over here are 56% of hematocrit, okay? And they have given the diseases metastatic disease, right?
Yeah.
So this is some kind. This
We
may
have
cancer.
sorry,
This may be some kind of carcinoma, right?
yeah, but what's this biopsy? It is very typical
There
and
is fatty
most commonly
cells. Yeah.
asked biopsy, and I think every student knows this. What do we have? If you look into one of
Really.
the cells, we have
Clear cell
clear
carcinoma.
cells. Okay,
That's renal
yeah, clear cell carcinoma. We call it renal
cell
Renal
carcinoma.
cell
cell carcinoma.
carcinoma. Okay, so this is a classic picture. Everyone should know this. Okay, and if the biopsy is there, if the biopsy is there, so it will be very difficult for you to just pick it up from the stem. Okay, so but I would like to go patient age. So age is important in this type of diseases, mostly in renal cell carcinoma. The risk factor for renal cell carcinoma is also given. Okay, 30 years of smoking, right? And we have increase hematocrit. Okay, got this?
Yeah, I mean, from the stem, it
So
feels like it's something to do with the lungs because they keep saying has chest pain and with deep breaths and smoking history kind of makes us think in the direction of some problem
yeah,
with the
yeah,
lungs.
you're right. Yeah, you're right. Yeah, but here the important thing is biopsy, okay?
Okay,
And the renal cell carcinoma can go to lungs, okay? It
okay,
can go to lungs, okay? The mets are going to lungs, bones, and liver, okay? So I am going to discuss some high yield points about renal cell carcinoma, okay? So
okay,
the first thing we see is clear cells, okay?
okay,
We call it clear cell carcinoma. Most common type is clear cell, okay?
okay,
And why these cells are very clear and what are they filled with? How they
Lipid,
yeah,
cytoplasm.
Lipid.
so we have lipids and carbs over here, mostly lipids, okay?
Okay.
And this is biopsy picture on grass anatomy for after removal of kidney, how it will look.
Yellow.
Yellow color, okay, because of lipids. Where is renal cell carcinoma developing? Originates from proximal convoluted
PCT.
tubules, okay? Got this?
Yes, sir. Yeah.
So the risk factor is smoking,
Age.
okay,
Smoking.
Yeah.
and age, okay.
Even
Mhm.
So
obesity too.
yeah, so if they have given you the age just from simply just from age, you can exclude the Williams tumor, right? So
Yes.
Yes, sir.
that
Yeah.
is of children's, okay.
Children. Yeah.
And the age is usually between 50 to 60 years, okay. Got this? What other
Yes, sir.
important things we have? Yeah, so sign and symptoms, how it will be presented. So
Hematuria
Painless.
mass.
Urea.
we will have, yeah, palpable mass on examination, okay. We will
Okay.
have hematuria
Flank pain.
and blank pain. And most of the time it can be asymptomatic, okay.
Yeah. In this
And
time, they didn't tell the
yeah,
about
and
hematuria or flank
other
pain.
things,
Metastasis.
Yeah.
yeah, and other things are weight loss, etc. They are common for malignancies, okay. And we can also see anemia and polycythemia, okay. Hematocrit is 56 here, okay.
Oh, okay. So that's why they give the hematocrit to
Yeah,
indicate
and
their stem.
the spread of this particular carcinoma is through blood, okay. Hematogenous
Blood.
spread.
Okay.
Hematogenous spread, where it goes, bones,
Bones
liver,
The lungs.
and most commonly
and
lungs, okay.
lungs. I see.
So you guys will remember this picture, okay.
Yeah.
So what's this?
Renal cell carcinoma, metastatic, most likely originated from the kidney.
Yeah, and they are
See,
yeah, you were right, the patient metastatic disease, so it is metastasized to, he has
The
chest pain and deep
lungs.
breaths, okay. So you are right, okay.
Yeah.
So it is coming from,
then they say
Kidney.
the patient metastatic disease most likely originated from which of the following lung? So it's
yeah,
originated from the kidney, but the sign
yeah,
Kidney.
symptom is showing the lung because it's metastasized to the
Yeah.
lung. So this time, if the patient is presenting with the sign symptom, mostly with the lung involvement, I think so.
Yeah.
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 So the sign symptoms
Exactly.
over here are the lungs, right?
Yes. Yes.
And the question asked is, where does it
Originates.
Originate.
originates? But the cigarette smoking is equally a risk factor for the problem occurring in kidneys, okay.
Okay.
But this is we know we are doing renal, na? But what in the how are we
Exam.
gonna?
Yeah. Exactly. That's what I was saying. It throws
So
us off to
yeah,
think
so
it's something with the lung.
yeah, you are right, but the thing is that it can metastasize to lungs. So you will study it, okay? Along with, yeah, you can say the common metastatic sites are lungs and bones, okay? Histopathology, rounded, polygonal, clear cells, okay?
But the
With
one clue
abundant,
like the hematocrit, increased hematocrit couldn't be in like a lung cancer. So it's
yeah, we
the
can see that in paraneoplastic syndromes, okay?
yeah
You are
the
right.
small cell cancer.
You're right. But this picture, the picture is atypical for renal cell carcinoma, okay? The biopsy is very typical for it, okay?
Okay.
And we also have in renal cell carcinoma, we have four paraneoplastic syndromes, okay? Where we have
Yes.
polycythemia, okay? We have
Hyperkalemia.
parathyroid hormone related peptides, ACTH and renin, okay? Got this? We
Yeah.
will have
Yes, sir.
erythropoietin, so it will lead to increase hematocrit. Hypercalcemia,
Oh, yes.
okay, parathyroid hormones will parathyroid hormone related peptide, okay, not parathyroid hormone, okay. Sometime it will be confusing in questions. ACTH and renin, okay.
You can just
Sorry.
hypercalcemia. Hypercalcemia.
Yeah, we will have hypercalcemia, okay. Yeah, so we have which of the following structure is most likely obstructed in this patient, okay. Which of the following structure is most likely obstructed? So obstructed structure, okay. 54-year-old healthy man comes to the office with leg swelling, no fever, chest pain, or dyspnea. He has smoking for 40 years, no alcohol or drugs use, afebrile, vital signs are normal. On physical examination, there is pitching edema floor, the abdomen is soft and non-distended, a mobile left flank mass can be palpated.
Hmm.
There are several vertical oriented tortuous veins on the abdominal wall. So, which of the following structure is most likely obstructed in this patient?
That's most likely inferior vena cava.
Yes.
Yeah, so the question is in 54-year-old first thing, right? Smoking for 40 years, okay? And we have the most important point we have is
Flat mass.
left
Flat.
flank mass, okay? That can be palpated. So the mass or the disease is causing the obstruction of which of the following structures? And we have given a hint that we are seeing a tortuous veins. Okay. So in abdomen, the femoral, iliac, and saphenous vein, they are down below. Okay. So they are not related to the veins that are tortuous in the abdomen. Okay. They are below the region. Okay.
Okay.
And the other thing is portal vein and inferior vena cava. So if we have obstructed vena cava, we can have tortuous vein in abdomen, okay? And the other
Hmm.
thing is portal vein. So in portal vein, like liver cirrhosis, we can also have tortuous
Capillary.
veins like
Yeah.
caput
You said.
medusa, right?
But we
Yeah.
won't have leg swelling and stuff like that in that, right?
Yeah, so in case of portal vein or liver cirrhosis, we will have sign and symptoms of
Yes,
liver cirrhosis like ascites, okay, esophageal varices,
yeah.
hemorrhoids, etc. Okay, and you will discuss this caput medusa and portal vein liver cirrhosis in coming module. Okay,
Okay, sir.
so what is happening over here that we have a patient that is most likely effect of renal cell carcinoma, okay, and this carcinoma is going through blood hematogenous spread which is blocking inferior vena cava, and due to back pressure we have tortuous veins, okay. Now you can see the picture. I think you guys are looking confused, but as for my concerns, we have two important points here: inferior vena cava and portal veins. The other three are down below the abdominal region, okay? So obstructing the femoral vein, iliac vein, or saphenous vein would not cause increased pressure in the abdominal veins, right?
Right. Yes,
Got
sir.
this, right? The
Yeah.
pressure is building below the obstruction point, right? Please, guys, be with me. I don't know you guys are getting it or not. Yeah, so we have inferior vena cava obstruction due to renal cell carcinoma. You can look at the
Mhm.
picture, okay?
Picture, yeah. Mm.
Was it difficult? Guys, please. Was it difficult?
No, sir.
No, no,
No, sir,
no.
you just have to
It is
eliminate
You
clear.
guys
the.
are so silent. I'm confused what I'm doing,
No, no,
what
no,
I'm
now,
doing right or not.
now clear, now clear.
Okay,
Yeah.
anyone please?
Which of the following is most likely causes the patient to A 54-year-old previously healthy man comes to the office due to several weeks of leg swelling, no fever, chest pain, or dyspnea. He smoked 40 pack years smoking history but does not use alcohol or illicit drugs. His afebrile and vitals are within normal. Physical examination, pitting edema on the lower extremities, bilaterally, abdomen is soft, non-distended. Mobile flank mass is palpated. Again, renal cell carcinoma. There are several vertical oriented tortuous vein on the lower abdominal wall. Further evaluation of microscopic hematuria laboratory shows leukocytes 9,000 normal, hemoglobin 19.2 very much raised, platelets are normal. What is the most likely cause of this patient's hematologic findings? The
Well,
paraneoplastic syndrome happening in the RCC?
so this is normal, right?
Yeah,
This is also normal.
uh,
Hemoglobin is increased, and the patient is
with renal cell carcinoma.
renal cell carcinoma. So, guys, if you have a patient of age more than 50 with a strong history of smoking, okay, and you see a left-sided or
Flank
a right-sided flank mask that can be palpated, it is
renal cell
more
carcinoma.
likely of a case of renal cell carcinoma, okay? And what it can do, hypercalcemia, okay, increase EPO, increase renin, right?
Yeah, increase ACTH.
Yeah, great. So we call it peer in your book. It's some mnemonic peer. You can remember it by that. So what does we have? The blood have increased hemoglobin. So if we look into the option B,
We have,
excess EPO production. Okay, got this?
yes.
Yes, sir.
Yeah. Anyone, please?
This patient lesion most likely originated from which of the following portion of the kidney? So, 50-year-old man come to the office for evaluation of abdominal fullness and mild right flank pain. He also reports weight loss of 4.5 kgs over the past 2 months. The patient has no other medical issues and works in a local industrial chemical manufacturing facility. Examination shows a soft abdomen. Ultrasound
Mhm.
reveals a mass in the right kidney. Subsequent
Mhm.
abdominal CT scan confirms the presence of a large right renal mass with evidence of necrosis. The patient undergoes right total nephrectomy. The specimen is shown.
Okay.
So the
So we have
patient,
a 50-year-old
mm,
man, okay, with a weight loss of
yes,
almost 10 pounds over
yeah,
the past 2 months, okay?
mhm, yes,
We don't have any further given sign and symptoms, but the CT scan shows presence of large renal mass, and upon
yeah,
nephrectomy, the specimen is given below. So now you look into the kidney, you can see a round
yellow,
yellowish
this,
Yellow.
yes,
mass, okay?
yeah, mass, yeah,
So what is
typical
it?
of RCC,
That's
typical
the
of
RCC.
RCC, yeah,
proximal.
And
mostly originated from PCC,
Proximal renal tubules.
yeah,
yeah.
and when you see the other carcinomas in a picture, so that you will be then easily
Mm, okay.
identifying. Okay, so we have golden yellow mass, okay,
Yes.
spherical or we can say rounded mass, okay. What are the other life? What are the other conditions look like? So it is angiomyolipoma. We will discuss it, but you
Okay.
can see into the pictures, okay. Oncocytoma, oncocytoma will be tan brown, okay?
The central
So,
scot
so the lipid accumulation is specific for
are
renal cell carcinoma, okay? And over here we have at the
urethral.
bottom of the picture, you can see the circumferential ureteric lesions, okay? Now you can see from the picture, what is it?
Again, clear cells.
Yeah, it's a clear cell.
Yeah.
Yeah.
So anyone who wants to go, which of the following
Oh, this is a
factor most
right,
likely
the same.
contributed? Yeah, which of the following factor is most likely contributed to the patient current condition? So you have diagnosed it from the
Smoking.
picture, and you know
Yeah,
the most important thing
smoking.
over here is smoking. But what
Smoking.
about the
Smoking.
family history? Yeah, it's important.
There is, yeah, I think in von Hippel-Lindau syndrome,
Yeah,
it can be hereditary. Yeah.
yeah. So how can we say that it's not because of family history? And if you
Gene
can
study.
see, yeah, if you can see, if anyone wants to read the question, we have given almost anything or everything, okay? Then
The
you can,
old woman comes to the office due to increasing low back pain. The pain is constant
Mhm.
no sleep at night. She also had a 15-pound weight loss over the last 3 months. Medical history is significant for osteoporosis and hypothyroidism. Family history is significant for breast cancer in her mother. She has smoked 1 pack of cigarettes daily for 30 years and drink 2 glasses of wine every day. Patient immigrated to the US from China 30 years ago. She mainly eats foods she cooks herself. Vital signs are normal. Physical examination show point tenderness over L3, L4 vertebra. MRI reveals lytic bone lesions in the corresponding vertebra and also a right lower pole kidney mass. Histological examination is shown.
so what we have given is almost every like alcohol use, diet,
Yeah,
ethnicity, family history, and smoking. But if you look into the family history,
that's positive for breast cancer.
so family history is positive for breast cancer. So they are talking about BRCA gene, right? And the breast cancer has nothing to do with
RCC.
renal cell carcinoma, okay? If they have given the history or the family history of something like von Hippel-Lindau, it would be
Genetic
the
cause.
option will be genetic or family history, all right? So they have given you the family history, but they are confusing it with breast cancer, okay? Got this?
The distraction, right?
Yeah. So I think they have, if you can see, they have given you a pack of cigarette for 30-year drink of wine, right? They have given you almost everything, right? Vital signs are normal limit and metastatic bone lesions. So they just want to know that whether you know the smoking risk factor and family history of VHL, okay?
Yeah.
Got this?
Yes.
Yes, sir.
So if you see, patient with strong family history of RCC are those with certain hereditary cancer syndromes like von Hippel-Lindau. Choice D, I am reading it, okay? Guys, choice D,
Yeah,
Okay,
Yes.
okay, sir.
this one,
Yes,
okay?
sir.
Yeah.
So, if a patient with a strong family history of RCC, if the patient has some history of RCC or those with certain hereditary cancer syndromes like VHL, okay, are increased risk of HCC. But here in our question, the strong family history of breast cancer may be associated with BRCA that are at high risk of breast cancer, okay? Got this point?
Yes.
Okay.
Yes, sir.
So what do we have? Anyone please?
CT scan of abdomen is shown below. A 64-year-old man comes to the office due to several episodes of intermittent hematuria over the past 2 months. He had
Mhm.
renal pain, burning or urination or fever, but has lost 4.5 kg since the onset of symptoms. Patient has smoked a pack of cigarettes daily for 30 years. Vital signs are normal limits. Abdomen is soft, non-tender, and non-distended.
Mhm.
Enlarged and firm prostate is palpated on digital rectal examination. Serum calcium is 12.3. Urine analysis shows 30 to 40 red blood cells, negative protein, and no casts.
So which of the following is the diagnosis? Look into the CT, guys. The right kidney is normal. We have a problem in left.
Left
Left
kidney.
kidney, it's enlarged, like a mass is there.
Yeah, I think the right is normal, right?
Yeah,
The
Yeah,
left is
so
normal.
as far
right
as
is
I know,
normal.
Okay.
this is right. This is right side. Maybe I'm wrong.
Yeah, this is right.
It's okay.
No,
Yeah.
Not differ.
right, yes.
Yeah, so we have 64-year-old man with a weight loss of
Okay.
10 pounds,
10 pounds, yeah.
smoked pack of cigarette for 30 years. Okay, the abdomen is soft, non-distended and enlarged, and firm prostate is palpated on DRE. Serum calcium is high. We have hematuria, no proteins, no cast, CT abdomen. So we have almost our diagnosis from here: 64-year-old, weight loss,
Past
smoking for 30 years,
Smoking,
increased calcium, and
calcium,
presence of.
urea.
Yeah, so I want to show you the pictures. Look into the picture closely, and if you see other pictures, you will understand. What about bladder cancer? So the CT given is at the level of kidneys, not bladder, right?
yeah.
So the first thing, if they have given you such questions like the CT is telling you that we are not looking into the bladder, we are looking into the kidneys, right?
Yeah.
Yeah,
Pheochromocytoma, pheochromocytoma, we will have.
Nothing there is no
Yeah. Like
given, nothing, no symptoms of
Yeah,
hypercalcemia.
we will have suprarenal mass, like the few
Yeah.
chromocytoma is in adrenal gland, right? And
Yeah.
we won't be having just serum calcium increase. We will have all the other sign and symptoms of the glands
Mm.
affected, right?
yeah.
Yeah.
Polycystic kidney disease. So in polycystic kidney disease, we don't see weight loss, right?
Yeah.
And most importantly, I have told you the
Bilateral
autosomal dominant is
dominant.
bilateral,
Bilateral.
right? So here we have the right kidney is normal and the left is affected. Okay. What about prostate cancer again? We have given here the prostate, firm prostate is palpated on DRE, right? So what
Yeah.
happens in prostate carcinoma? We have
There'll be hard. Yeah.
nodular hard prostate, okay?
Yes.
And what about renal stones? So we will have gross hematuria,
I
okay?
remember this.
We will
No
have
hypercalcemia.
right, maybe
Maybe
the
nephrosis.
calcium level are high, maybe the stone
Mm.
is of calcium oxalate
Ah,
or something like that, but
yes.
we don't see that much of weight loss
Yeah.
in.
Yes.
Weight loss.
Sir, what did you say about pheochromocytoma?
Yeah, the
What
first
point did you
thing
say?
the first thing about pheochromocytoma is the location of the pheochromocytoma, okay? It is in adrenal gland, okay?
Yeah.
Right?
Yes.
And the second thing is you will see hypertension or the increased level of
Episodic hypertension.
epinephrine, etc. They will be deranged, right?
Yeah.
Yeah.
Now, I want to show you the picture of, yeah, so you can see this one, but I want to show you the picture of where it is pheochromocytoma. suprarenal mass. Okay,
Mm.
now you can see over here that the mass is not affecting the
Kidney,
directly
yeah, okay.
the parenchyma of kidney. Okay, not in
Mm.
inside the kidney parenchyma. Okay, and if you see
Mm.
closely over here, you can see the mass is affecting
Separate
it.
from
Okay,
this.
and you will see the we will discuss in detail about pheochromocytome. Okay, and endocrine. Yeah, anyone please.
Which of the following is most likely to be discovered on further follow up of this patient's symptom? A 68-year-old man comes to the office due to episodes of gross hematuria over the last 3 months. Blood is present throughout micturition. The patient has no abdominal pain, dysuria, urinary frequency, and nocturia. Medical
Mhm.
history includes type 2 diabetes mellitus, for which he takes metformin. The patient is retired, lives at home with his wife, and spends most of his free time working in his backyard greenhouse. Prior
Mhm.
to retirement, he worked at a rubber manufacturing plant for 35 years. Vital
Mhm.
signs are within normal limit. On examination, the abdomen is soft and non-tender with no palpable masses. Serum creatinine is 1.1. Which of the following is most likely to be discovered on the further follow-up of this patient's symptom?
So we have 68-year-old man, episodes of grass hematuria over the last 3 months. Blood is present throughout maturation. This is high yield point. Blood is present. Blood is present throughout maturation. No abdominal pain, dysuria, urinary frequency, or nocturia. Medical history include type 2 diabetes, taking metformin, the patient is retired, spend most of the time working in backyard. Prior to retirement, he worked as a rubber manufacturing plant. Vital signs are within normal limit on examination. The abdomen is soft, non-tender, and non-palpable. Serum creat is normal. The following may be discovered per the workup of the patient. So, what do you think, guys? Let's do
Is
it
it
on.
going to be bladder cancer?
Yeah,
Because this risk factor, this age, and it's rubber manufacturing
Yeah,
plant.
rubber
yeah.
There's also
This
a
is
risk factor,
important, right?
and the gross hematuria too.
So we have discussed the glomerulonephritis, right? Let's go through which we already know, right? So what will happen in glomerulonephritis?
We'll
Anyone,
see
please?
cast, red cell
So
cast.
we will have red cell cast, right? We will have dysmorphic RBC, we will have hematuria, maybe we have proteinuria, right? But
Yes,
not
sir.
gross hematuria, okay? We will have cast.
Cast.
Okay, what about polycystic kidney disease? We will have enlarged kidneys. At that age, it will be bilateral, okay, and maybe causing azotemia, okay. Prostate
Yes,
cancer. What about prostate cancer?
there is no
So,
Urinary
Heart.
symptom, any
yeah,
obstruction,
so
frequency, and
we know we don't
okay.
have any dysuria or urinary frequency or nocturia, and even the blood will be present at the start of maturation, okay. Blood is throughout maturation, okay. Staghorn calculus, it can cause gross,
flank pain, gross hematuria.
yeah, it can cause gross hematuria, but we will have costovertebral angle
Angle tenderness.
tenderness. Okay. What about interstitial cystitis? It causes high grade bladder pain. Okay.
Suprapubic pain.
The pain is very much significant. Okay. So the only thing we have left with is bladder cancer. So what is important in bladder cancer that we will have gross hematuria, okay, and painless, okay, this is important. Painless gross hematuria and work in rubber industries where we have mines, or what other things that causes the bladder cancer? What are the other things?
Dies.
Pains.
Dies.
Pains.
Smoking.
Guys,
Schistosoma also.
Remember,
Wait.
Schistosoma infection.
smoking is risk factor for renal cell carcinoma as well as bladder carcinoma. Okay, we have smoking, amines,
We have cyclophosphamides.
and we have cyclophosphamide, and I think they have given some other
Acetylene.
like alcohol or something, paint industries. Okay, so we will see that. Okay,
Yeah, I was also thinking about like he is working in the yard, so snails are there. So it doesn't it could lead to the schistosoma hematobium thing.
yeah, but the schistosoma, they will give you the location. Okay, it's more common in Africa and Middle East. Okay, got this?
Got this.
They will tell you
Yes.
about where schistosoma is more common. Okay, yeah, aromatic amine, dyes, textile, leather, plastic, rubbers. Okay, so you guys have to remember this: rubbers, plastics, amines, dyes, textile, and leather. Okay, got this?
Yes,
Yeah,
sir.
I think you were talking about in Africa and Middle East, the schistosoma is associated with
Multiple types of cancer.
squamous cell carcinoma. Okay.
Mm.
Yes, please.
Which of the following is a major risk factor for the patient's current condition? A 68-year-old man comes to the office due to intermittent painless blood in his urine. No other symptom. Patient uses transdermal testosterone for chronic hypogonadism and erectile dysfunction. He smoked backup cigarettes daily for 40 years. 2 shots of vodka for every 2 glasses of wine. Works as operation manager for large beverage company and frequently travels to Mexico. Vital signs are within normal. Abdominal examination show no abnormalities. On DRE, prostate is smooth with no nodules. Urine analysis is positive for greater than 50 red blood cells, no cast or dysmorphic RBC. Urine cytology is positive for malignant cells. Renal ultrasound reveals normal kidneys. Which of the following is a major risk factor for this patient's current condition?
So they have given you the urine cytology is positive for malignant cells.
This is
Okay.
bladder
So we
cancer.
have to find out which type of malignancy it is. Okay.
Yeah,
So
broken heart.
renal ultrasound shows normal kidney.
This is not renal cell carcinoma.
So we can exclude
Renal cell.
the carcinomas of
Mm.
kidney. Okay. Which of the following major risk
Kidney.
factors? So let's check it
Also
out.
prostate.
So painless blood in urine. Okay. Intermittent painless blood in urine. Okay. He has no other symptoms.
Mm.
So other carcinoma like prostate cancer, he has only painless blood.
Yeah.
So no obstructive sign and symptoms of
B BPH
prostate
Urethra.
prostate cancer. Okay. So we have
Yeah.
excluded kidney, we have excluded prostate cancer.
Prostate.
Okay. So we have a risk factor of cigarettes. Okay. So we know cigarette smoking can cause urothelial carcinoma. Okay.
Yeah.
Bladder cancer. He also has traveled to Mexico, so they are confusing you. We know it is common in Africa and Middle East. Okay. Vital signs are normal. Abdominal examination shows no abnormalities, so no mass or something like that. Okay.
Yeah.
No cast, no dysmorphic RBC. So it is mostly, we can say it is,
Bladder cancer.
Bladder cancer.
okay. We call it urothelial Carcinoma, okay. So what is the
Carcinoma.
risk
Yeah.
factor? He is using alcohol, right? They
Mm.
did not give you have they given you the occupation? He was
Nope.
No,
manager
just large
for large
beverage
beverage
company. Yeah.
company. So the alcohol can cause cancers of GI, but
Mm.
not
Yeah.
bladder cancer. Okay.
Yeah.
On no abnormalities and DRE also we can exclude this. Okay. So we have excluded travel history. We have excluded this one. We
Occupation.
have excluded occupation, right?
Yeah.
So we have remaining testosterone therapy. It can cause prostate cancer, can be a risk factor, but we have excluded that, right? Prostate cancer has
Yeah.
been excluded. So the only thing, and we also know that the tobacco smoking is a risk factor, okay?
Yes.
Yeah, again, we have the same picture. Renal.
So, sir,
Mm.
what
Yeah.
was the
Lip.
cancer in the previous question?
Bladder cancer.
Bladder cancer. Okay, thank you.
Okay. Anyone, please?
Which of the
What of the following process most likely accounts for the abnormal appearance of these cells?
Mhm.
Uh, big question.
So, without looking
Yeah.
into the stem, what do you see?
Yeah.
We have,
Clear
Renal
cell.
cell carcinoma.
and what is accumulating in renal cells?
lipids and carbo
Carbohydrate.
Yeah, so the first option
Carbohydrates and
is
lipids.
lipids, and
A.
now you can
July
go through
15
the
and lipid.
stem. Yeah, anyone, please go with this question.
Okay. 65-year-old man come to the office for evaluation of blood in the urine. The patient has no abdominal pain, urine frequency, or urgency. He has hypertension,
Mhm.
type 2 diabetes mellitus, and stage 2 chronic kidney disease. He quit smoking 10 years ago and had smoked a pack of cigarettes daily for 30 years. On
Mhm.
examination, vital signs are within normal limits. The patient BMI is 33. After appropriate workup, the patient undergoes renal biopsy. Histopathologic findings are shown below.
Mhm.
So here,
So,
due to obesity,
what do you guys
risk
think it
factor.
is? So we have 65-year-old old
Yeah,
man.
yeah,
I'm just
maybe.
for a revision, okay? 65-year-old man, the patient has no pain, urinary frequency or urgency, okay?
Yeah,
Stage 2, CKD, diabetic, smoking for 10 years, pack of cigarette, quit smoking for 10 years, but he had a pack of cigarettes for 30 years, okay? Vital signs are normal limit, the patient BMI is that much. After
mm,
appropriate workup, the patient renal biopsy and histopathology findings are renal cell
carcinoma,
carcinoma. We have accumulation of
lipid and
lipids
carbohydrates.
and carbohydrates. Okay. Yeah. Yes, please.
urine analysis in this patient would most likely reveal which of the following. A 57-year-old man come to the hospital due to nausea, vomiting, and severe crampy pain in the right.
Mhm.
He also had no fever or chill. Several days ago, patient had similar but less severe pain and resolved spontaneously. Medical history is significant for type 2 diabetes mellitus, obesity, hyperlipidemia, hypertension, and gout. Temperature is 37, blood pressure 160/100, hypertensive, blood pulse is 98. Physical examination show right flank tenderness. Blood, urine, nitrogen, and serum creat are normal. Ultrasound reveals right-sided hydronephrosis and proximal ureteral dilation. Urine analysis will likely reveal which of the following.
So what do we have?
Maybe a stone that's
Yeah, great. So we have a 57-year-old with nausea, vomiting, and
obstructed.
severe cramping pain in flank. So we
Yeah,
have a flank pain,
yeah.
nausea, vomiting, no fever, no chills,
So that
Several days ago, the patient had similar but less severe pain that resolved spontaneously. Medical history is significant for type 2 diabetes, obesity, hyperlipidemia, hypertension, and gout. Okay,
yeah.
so we have type 2 diabetes, obesity, hyperlipidemia, hypertension, and gout.
Mm.
Blood pressure is elevated, pulse is 98, physical examination shows a right flank tenderness. Okay, urea nitrogen and creatinine are normal. Ultrasound shows
Right hydronephrosis.
right-sided hydronephrosis, proximal ureteric
And
dilation. Your analysis of the patient would most likely. So, what is our diagnosis? We
that's
have
cal-
severe pain, flank pain,
Yeah.
history of gout, okay, flank tenderness, no fever, okay, and right-sided hydronephrosis and proximal ureteric dilatation. So it's pretty obvious, right?
mm.
Yeah.
So we have some stone that is causing hydronephrosis and ureteric dilatation, okay?
Mm.
Right flank pain. So the pain could be due to other reasons, but the ultrasound told us that we have dilatations, okay? And specifically this one, the proximal ureteric dilatation. So if it is some other problem like congenital problem, so we will have either bilateral hydronephrosis, we have discussed these, right?
Yes.
Or we will have the ureter that will be dilated all the way, not just proximal ureter, okay? And we also have a history of gout, okay?
Yeah.
So all these points can lead to
Stone for
kidney stones, okay?
yeah.
And what do we see? What do we see in stones? Not
Hematuria.
malignant cells, not cast, okay, not white blood cell cast. And what about this one? Yeah, what is normal specific gravity? I think it's 0.1003 to it's 0.1030. It's something like that, right?
Mm.
So the normal specific gravity is 1.003 to 1.03, okay? So the specific gravity is
Reduced.
reduced, right? And it shows the either the urine is concentrated or not. So if it is elevated, we can say the urine is concentrated, okay? Just simply remember that the normal value is this, right? And if we had 1.04 or something like that, we can say that the urine is concentrated, and this concentrated urine favors stone formation, okay? Got this point?
Yes.
So we have decreased specific gravity, which is not favoring the stone formation, so we can exclude this as well, okay? So if we had an option like if this is not present and we have specific gravity of 0.3 or 1.04, this will be correct, okay? Got this?
So why would that be increased in this case?
In any condition like in dehydration, severe fluid loss, or sweating, or some other conditions like increased concentration, or the urine is more concentrated because of gout or some other conditions like hypercalcemia, etc. This will be raised, okay? This will be
So you're
raised,
saying,
and it will favor. It is showing you the either the urine is concentrated or not, okay?
so the specific gravity is the same as increased urine osmolarity?
Yeah,
Urine, okay.
we can say the concentration, okay?
Urine, Concentration.
So, yeah. So if the concentration, okay, or the specific gravity is more than normal values, it means that we have concentrated urine, okay? And when, like in gout or dehydration or exercise, after exercise or fluid loss, etc., we have concentrated urine. It favors the formation of
Stones.
stones, okay?
Stones. Okay.
So in so what do we have? We have kidney stones, okay? And what can stone cause? Gross hematuria, okay? Got this?
Yes, sir.
Yes, sir. Thank you.
Yeah, so what's in the picture? Anyone? What's in the picture?
Kidney stone.
Yeah.
Stones.
So further evaluation of this patient would most likely reveal which of the following. Now we have a 54-year-old woman.
Staghorn
Sorry?
stone. It
Yeah,
is
so
what's called the Staghorn.
yeah, we are looking into these stones, okay? So we have a 54-year-old woman with fever, nausea, vomiting, and confusion. For the past 3 days, dysuria, painful urination, increased frequency. Medical history is significant for recurrent urinary tract infections and primary hypertension. Family history is significant. Temperature is elevated. He is dehydrated, or we can say BP is low. Respiration is above normal. Examination shows right flank tenderness. The patient undergoes nephrectomy and cut section of the kidney shows this. So we have given the stones, okay? Now you have to find out which type of stone it is from the stem, okay? Guys, you know this. We have four type of stones, right?
Okay.
Four
Yes, sir.
type of stones, okay? I will make it easy for you. The cystine stone. What about the cystine stone? It is
Hexagon.
hereditary, right? It is hereditary, okay? We have a problem in cystine transporters, okay?
Yeah.
So this one is hereditary, okay? And they will be talking about amino acids, okay, in a stem. Got this?
Yes.
Yes.
The other three, how can we differentiate that? One is uric acid stone, okay? So uric acids are
Associated with gout, always.
gout, okay, great.
Increased
And
cell
and some increase cell turnover like leukemias, okay?
leukemias,
Hemolysis syndrome.
tumor lysis.
Okay. Yeah, great. So increase cell turnover, okay? So the remaining two, calcium stone, like calcium oxalate and calcium phosphate, and the last one is AMP or
MAP, magnesium, amine,
ammonium magnesium
phosphate.
phosphate stone, okay? We call this white stone, okay? And here the important point is most of the time the straw white stone lead to stake on stone, okay? Got this? In calcium
Yeah.
stone, we will have increased calcium, okay? Or we
But
can
our
say,
options
sorry?
we can have staghorn calculi in both cysteine too, and even in the
Yeah, yeah. But I am giving you the high yield points just to exclude the or just from the stem you will easily get it, okay?
okay.
So the calcium stones you will have increased calcium levels, okay? Got this?
Yes, sir.
Yes, sir.
We will have
Yes.
increased calcium or something they will be talking about parathyroid, okay? Got this? What about
Yes, teacher.
magnesium stone and magnesium and store? It is staghorn, and the important thing is it is caused by bacteria, okay?
Mm.
The bacteria are forming ammonium, which leads to ammonium magnesium phosphate stone, okay?
Yeah.
These bacteria have some enzymes that convert urea into ammonium, okay? What about
Yes.
uric acid stone? Important point about uric acid stone is it is,
Associated with gout.
yeah,
You
it is
mean this?
associated with gout, and it is radiolucent, okay?
Yeah. Also acidic, I think, pH.
Yeah. About acidity, the only bacteria, sorry, the only stone that is favoring increased pH is AMP, or we can say ammonium magnesium phosphate or steroid stone, right?
Yeah.
Because bacteria favors this, okay? The
Mm.
other three, we will have decreased pH, okay?
pH.
Got this?
Yeah. Yes.
So if they are talking about something like hereditary or a problem in proteins,
Childhood.
amino acids, etc. Okay, so we will have
Sustain.
cysteine.
Sustain. Yeah.
Okay, and if they are talking about gout or radiolucent stone or something like that, okay, so we will have uric acid stone. Okay, and gout and increase cell turnover like tumor lysis syndrome, leukemias. Okay,
Yes.
about calcium. So they may be talking about increased calcium level or in diet they have taken increased calciums. Okay, or
Yes.
malabsorption, etc. Okay. So now with some of the basic knowledge, now we can look into the question and see what we have. So he has fever. Okay. He has fever, okay? Nausea, vomiting, confusion, dysuria, and painful urination, okay? And increased frequency. So what does it tells us? That
UTI.
we have a stone,
Pyelonephritis.
Infection.
we have a stone
Yeah.
along with
Yeah.
fever.
Infection. Yeah.
Stone plus infection.
Stone plus UTI, right?
Yeah. So recurrent urinary tract infections.
Infection.
Also, they have given it here, okay?
Bacterial,
Yeah.
right?
So subsequently. So now I think you can guess it.
That's
Which type of
bacteria,
stone it can be?
magnesium ammonium phosphate, the struvite stone.
Yeah,
Mm.
yeah.
Fine.
So if the same picture with the stone is given and they are talking about like cysteine transporters are
Mm.
affected or it is in a children or a child, so it will be cysteine stone, okay?
Mm. Yeah. Yes.
Now here they are talking about infection. So which two bacterias are most common for this? Klebsiella
Proteus.
and
Proteus mirabilis.
Proteus, and Klebsiella. Okay.
Yeah.
Yeah, so let's look into the options. What are they asking? Further evaluation of most likely.
C.
Is it low
Yes.
pH?
The
Is it low
pH here
pH?
will be high.
Yeah. What about
Yeah.
parathyroid tumors? If the PTH is high, we are
Having
the calcium will be
Calcium. Yeah.
high. We will have
Yeah.
calcium stone. Okay.
Calcium stones. Yeah.
Klebsiella infection, Stackhorn stone.
yeah.
Okay.
Yeah.
High urinary cystine excretion.
Cystine stone.
So I have told you, the cystine stone. They will tell us about something, some signs, some pathognomonic for the cystine problem. Okay. Yeah.
Okay.
So
Sir, why not E. coli in the last question?
sorry.
So why not E. coli, like the bacteria? Why not E. coli? Because it
Equal
also causes the cystitis. Like it's the main, like I think it's the main cause of cystitis. So
Yeah.
why
So
not?
E. coli is the
The
main. Yeah, the E. coli is the main
yes.
cause of UTI, right? But
Yeah.
it is not the bacteria that is converting urea into ammonium, right? And that's
Okay.
why it is not the common cause of forming stones. Okay.
Okay. Okay. Okay. Got it. Thank you.
So anyone, please.
The patient kidney are most likely to demonstrate which of the following findings. A 68-year-old man's come to office due to weak urinary stream, hesitancy, and straining on micturition. The symptoms have been present for the 2 years but gradually become more severe and are beginning to affect his quality of life. Patient recently started noticing continuous urine leakage, nocturia, frequent urination, and urgency. No other medical problem,
Mhm.
no medication. The patient does not use tobacco or alcohol. He's a business management consultant and motivational speaker. Vitals
Mhm.
normal, BMI is 27. The patient kidneys are most likely to demonstrate which of the following find is. That's the BPH symptoms, na? Benign prostatic hyperplasia.
Yeah.
So that's actually causing the obstructive symptoms.
Yeah. Great.
So kidney
So
will
so we
have
had 68-year-old with weak urinary stream, hesitancy, and straining on micturition. Okay. So we have the obstructive signs of BPH. Okay. Present for the past 2 years, gradually become more and more, beginning to worsen his quality of life. The patient recently started noticing continuous urine leakage. So he has BPH for the past 2 years. Now he has continuous urine leakage, nocturia, frequent urination, and urgency. He has no other medical condition and take no medication. The patient who does not use any tobacco or alcohol. So if he is not using tobacco, so we can somehow exclude the cancers. Okay. He is a business management consultant, motivational speaker, BMI is 27, most likely to demonstrate which of the following findings. So what do you think, guys? Glomerulosclerosis and hyalinosis. We have discussed it is present in FSGS and diabetic nephropathy, right? Causing nephrotic syndrome. Hyperplastic arteriolar changes, we have discussed that in malignant hypertension, right?
Yeah. Yes.
Yesterday we had lots of MCQs on acute tubular necrosis, whether it's ischemic or
nephrotox.
nephrotoxic. Is there any sign and symptoms of ischemic tubular necrosis?
No.
No.
What are they?
This can cause pressure atrophy, I guess.
Mm.
Parenchymal
Yeah, we are getting there. Great. So,
The second.
what were the tubular necrosis sign and symptoms?
we have muddy brown
Muddy
granule,
brown cast.
Great. Muddy brown cast and
and we have two phases in which we have one is oliguria and then we have recovery phase with polyuria and
yeah,
hypotension.
we have Yeah, great. Hyperkalemia phase, then
Yeah.
hypokalemia phase.
Hypokalemia.
We will have brown medicast.
Yeah.
Okay. We will have hematuria. We will have some toxic injury. So the toxin will be given. Either he will be dehydrated, heart failure, any cause of decreased blood flow. Okay. Tubular
Yes.
epithelial dysplasia, or we can say precancerous condition is a dysplasia. Okay.
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 So the only thing we have left with is parenchymal pressure
Pressure.
atrophy. Okay.
Yeah.
So
D.
what is parenchymal atrophy? Pressure
Most
atrophy.
of the high pressure, back pressure,
So simple, we can
because of
say
obstruction.
So the
parenchymal
pressure cross.
atrophy due to
Mm. The pressure.
back pressure. So
Yeah.
damage to the parenchymal tissue due to the back pressure. Okay.
Pressure. Yes.
So what can lead to, what other conditions can lead to parenchymal, or we can say atrophy? What
Overflow
other?
is also associated with this, right?
Sorry.
Ureteric stones.
Continence.
So the first is given, right? Ischemic, right?
Yeah.
No, sorry, it is ischemic is here. Sorry. So we have discussed in renal artery stenosis, right?
Yeah.
We have shrunken kidneys, right?
Yeah.
Uh,
Yes.
we have discussed it in hyaline arteriosclerosis due to diabetes or hypertension. When we have decreased blood flow for longer duration, we can have atrophy, okay?
Yeah.
The other thing is chronic pyelonephritis can lead to necrosis of the tubules, okay? Pelvis,
Atrophy and scarring.
yeah, great. Obstructive, we have discussed the obstructive, sorry. So we are discussing here the obstructive one, right? Pressure atrophy, stones, BPH, etc. Okay.
Yeah.
So
So
now
this is
you know.
also overflow obstruction, right, sir?
Yeah.
BPH causes overflow obstruction.
Yes.
y- Yeah. So we call it overflow incontinence. Okay.
Incontinence, yeah. So for overflow incontinence, what's like the main uh, symptoms we have to focus on as compared to the other incontinence?
Yeah. So overflow incontinence, we have discussed two or
Mm.
three causes, right? What were they?
BPH and
Posterior wall.
Yeah.
spinal cord
BPH,
Obstruction,
spinal cord injuries,
spinal
diabetic
cord.
neuropathy.
uh,
Okay. So the
Oh,
overflow means that the bladder is getting filled. Okay. And
oh,
we have
in case of
Yeah.
like spina bifida, myelomeningeal seal, the bladder is not getting empty. Okay.
Yes.
we have
okay,
a
Same for,
muscle
sorry.
Mm.
the muscle's not active, right?
Yeah. Yeah. Right. So we have the innervations are affected, right? Same is
yeah,
Yeah.
in the diabetic nephropathy. So the detrusor muscles are not contracting. In spina bifida, we have injury to S2 to S4 neurons, right?
Mm.
yeah,
So
Yeah.
the muscle activity is not there. So we are getting the bladder filled all the time, right? That's why
okay.
we call it overflow incontinence. Okay. In
Oh,
such cases, we have urine dribbling, constant urine dribbling. Okay.
okay, okay. Thank you.
So next question.
Which of the
Most like,
following most
mm-hmm.
likely? Oh, someone else
Uh-huh.
want to. Which of
Yeah,
the
go on.
following most likely?
It's okay.
Okay. Which of the following most likely accounts for this physical examination findings? A 46-year-old woman being evaluated for irregular vaginal bleeding is found to have invasive cervical cancer. She undergoes total abdominal hysterectomy and bilateral salpingo-oophorectomy. Pelvic lymphadenectomy was also performed, during which several enlarged nodes around the pelvic vessels were resected. A week after the surgery, the patient begins to experience left-sided flank pain that radiates to the groin. Her temperature at 36.1, blood pressure 120/70, and pulse 84. On physical examination, there is a palatable left kidney mass. Which of the following most likely account for this physical examination finding?
Yeah, so we have a patient, 46-year-old
Yeah.
old female with a history of cervical
So,
carcinoma. She undergoes total hysterectomy and bilateral salpingo-oophorectomy. Okay. Pelvic lymphadenectomy was also performed, during which several enlarged nodes and pelvic vessels were resected. Okay. A week after the surgery, the patient begins to experience left-sided playing pain that radiates to groin. His temperature is normal, blood pressure is normal, pulse is normal. On physical examination, there is left flank ballotable mass. So the following is most. So I think we have discussed this one, right? If you guys remember it, I have told you
yes, the
that
ureter.
yeah, we have. I have told you in gynecological procedures, the ureter got injured, right?
Yeah,
So
obstructed.
yeah, so in such surgeries, the ureter is being ligated, and I have told you the course of the ureter. What was that?
Water under the bridge.
First,
Yes,
yeah.
yeah.
So three things were we have discussed three things, right? In
Yeah,
proximal portion, the ureter is going below gonadal arteries,
little
okay?
arteries. Yeah,
Then above iliac arteries,
Then
and
below
at
you,
yeah.
last
Below uterine.
below
in
you.
pelvic
Mm.
portion, it
Yeah,
is going below
below
the
the
uterine
uterine artery.
artery, okay? So here they have cleared out the pelvic, they have done pelvic lymphadenectomy, total hysterectomy, bilateral oophorectomy, okay?
Yes.
So they have injured or sorry, ligated the ureter. Got this?
Yeah. Yes.
So what do you think can happen?
Hydronephrosis, this backward
From
pressure.
back pressure.
Yeah, great. So it is hydronephrosis. If you look into the other options like acute interstitial nephritis, so we have discussed the AIN, which is due to drugs, okay? You will have fever, rash, etc., etc., right?
Yes.
So we
Yes.
don't have such things in our question, okay?
Yeah.
Renal cell carcinoma, again, they didn't have told us that she has some sign and symptoms of renal cell carcinoma,
Yeah.
okay? If we look again into the stem on physical examination, temperature is normal. So there is no such thing that we can say it is renal cell
Yeah.
carcinoma, okay?
Yeah.
Same for the cystic disease,
Mm.
okay? We don't have any
Mm.
cysts. What about
Normal blood.
vesico-ureteral reflex? So again,
It will be bilateral
yeah,
or
great point. Yeah, it will be bilateral. And what about renal vein thrombosis?
It cannot develop in such short time, right? Time, acute time, 1 week hours after surgery.
Yeah. So I think it's a classic question. Everyone should get it right. Yeah, they have given the same ureteric course. Don't need to go through again, right?
yeah.
So this vesicular reflux, why is that not the option? When there's obstruction, won't that be a possibility?
Yeah, but the vesico-urethral reflux is first thing is it's not that much common in such surgeries. Okay,
Oh,
it
okay.
is more common in they have given here is in bladder surgery. Okay,
Okay.
or prostate surgeries. Okay, and the high yield point here is it will be any obstruction which cause the problem in both ureters. Okay.
Okay, sir. Okay. So it'll cause in both ureters.
Yeah, so the problem will be bilateral. Okay.
In the case of what?
Like if something is blocking in the way, right?
Oh, so
Like
both
if we
sides.
have if we have some problem to the bladder, or we
Yeah.
have BPH, or we have posterior urethral valve,
Yeah.
or BPH or prostate carcinoma. So all these lead to back pressure, okay, in both sides. Yeah, anyone please?
Okay, sir. Thank you.
Which of the following is most likely underlying mechanism leading to the stone formation? Actually, they told us the microscopic analysis stone reveals a pure uric acid stone. A 46-year-old woman is admitted to the hospital with dehydration secondary to excess output from an ileostomy. 5 years ago, the patient had total colectomy with a diverting ileostomy for colon cancer. For the last 6 months, she had increased output from the ileostomy and had been admitted to the hospital twice for similar episodes of dehydration. On the second day of admission, she reports right flank pain. X-ray reveals a non-specific bowel gas pattern with no evidence of renal calculi. Ultrasound abdomen show a 4 mm stone in distal right ureter. The patient is treated with analgesic and stone passes spontaneously. Stone reveals a pure uric acid stone. What is the most likely underlying mechanism? So you actually told us the
So
uric
they
stone
have
is
given you the stone is pure uric acid. Yeah, go on, please.
it's formed due to increase something like gout or tumor lysis or leukemias or lymphoma can cause uric acid. And they actually has told us that we have excess dehydration. So concentrated
Yeah, great point. Yeah,
lead to and the pH is acidic. So concentrated acidic urine is the cause of the stone
yeah.
formation.
So actually, they have given us two, three high yield points over here. The first thing they have told us the type of stone we have, right? Pure uric acid stone, right? The second thing is the patient is dehydrated, okay, and X-ray of the X-ray of the abdomen reveals no evidence of renal calculi, right? But the ultrasound abdomen shows 4 millimeter of stone in the distal right ureter. So what does this mean? Yeah, guys, please.
Radiolucent in
Yeah.
X-ray.
So it is radio.
Lucent stone.
So uric acid stone are radiolucent, and what is the cause, or what is the reason for the stone formation? Dehydration, okay? Because he has excess output from ileostomy, okay? Got
It's a
this?
lysis, right? Lysis, yes.
Sorry?
I mean, it's like a lysis because due to radiation, right? Lysis.
I don't get your point. Lysis? Sorry?
Tumor lysis syndrome, she means.
No, so we don't have anything here like tumor lysis syndrome, but we see the uric acid, the what's the what we call it? What's the accumulation here? Urate mono? What is this? I forgot.
Monosodium urate
Monophosphate.
mono
Yeah, something UMP, something like that. So we have uric acid stone because of
Accumulation.
Accumulation. And when did they accumulate? When we have increased concentration in urine, right? And the concentration or the specific gravity increased when we are dehydrated, okay? So this dehydration leads to increased concentration of uric acid, okay? And when the urine get concentrated, they are getting to form stones, okay? Got this?
Yes, sir.
Yeah, so if you
Yes.
look into the other options, bile salts, malabsorption, it will cause the formation of calcium stone, concentrated acid urine. So yeah, acidic urine can form some type of stones, but here we have severe dehydration, okay? Increase uric acid production, so it can be, but in gout, okay? Infection of urea splitting bacteria, so
That is MAP, AMP, sorry, ammonium
yeah, ammonium magnesium phosphate stone, okay? Overproduction of parathyroid hormone, increase calcium, okay? So you can do the question either ways. If you do not get the stem completely, so you can go through the exclusion method. Exclusion method will make the question easy for you. Like we have excluded just from knowing that we have just from the fact that they have given us that the stone is uric acid, right? So we excluded this. We excluded this, right, guys?
Yes, sir. That's
So
right.
we know it's uric acid stone, right? So
Yeah.
parathyroid hormone will lead to calcium stones.
Calcium
Urea
stone.
will lead to spheroid stone
Right.
and increase uric acid production. Concentrated acidic urine or bile malabsorption. This is bile malabsorption will also lead to
calcium.
calcium stones, okay?
Calcium
Calcium
stones.
and oxalate stones, okay?
Yeah.
And the reason for this is the oxalates are normally removed by kidney, but in such cases, bile salt malabsorption, we have decreased removal of
Of
oxalates, okay? And concentrated acidic urine and increased acid production. So increased uric acid production will be in gout, right?
Yes, sir.
So you got your answer right.
Yeah.
So I think it's enough for today. We have, I think you guys have another class, right?
The
Yes, sir.
micro class. Yes.
Yeah, and we almost done with the 20 questions, so I think it's enough for today, okay?
Good.
I
Yes.
thought I thought today class is
Yes, sir.
easy because we have two or three things, right? Uh, what we have discussed is for now, we have discussed the
Renal
renal cell
cancer,
carcinoma, urothelial carcinoma,
also
some types of stones,
stones,
and what else?
also acid-base balance to some
Yeah,
extent.
to some extent, the acid bases were
Yeah.
already being discussed, right? So we have discussed acid base. So the questions of from today topics were very easy. You just need to know the high yield points from renal cell carcinoma and urothelial carcinoma. Okay, just like the yesterday, we have ATN, AIN. So I think you guys should have mastered these two, three topics each day, right?
Yes, sir.
Inshallah.
Definitely.
Yes, sir.
Yeah.
Thank you so
So
much
Yeah.
for your help.
thank you guys.
Thank you so much,
Yeah,
Dr.
Thank you,
Hisham.
and
sir. Take care. See you.
Thank
one
you,
last
sir.
question. Sorry,
Uh-huh.
sorry, sorry for.
No, no.
So, doctor, you were yesterday you were asking me about the marathon program. So today the program has started, and sorry
Yes.
I didn't knew your name so that I could have texted you.
Oh, no, no, sir, no problem. So I thought like I'm gonna stick with your program. Like I'm gonna be
Okay.
doing the question. I find
Okay.
that more helpful because like rather than listening to a long lecture, I find your class to be more helpful. So that's why I thought I will first do this and see how my scores improve. And
Mm-hmm.
I have a feeling it will be fine after this. So that's why I
Yeah.
decided
Okay.
I'll just
There's great.
focus
Okay.
on this.
Yeah,
Yes.
just
So thank you so
I
much.
will suggest that everyone should go through the first aid again and again. What happens in our programs that students are satisfied at the initial phases of the program, but when we are entering to the last phase, what happens that students do not study by themselves, and when they get to know that they have forgot things or
Yeah.
something is not good with their studies, so they are at the end they are not happy. So I will say each and every day to you guys that be with be with us in our studies, do your homework, do the daily task, and yeah.
So, sir, going forward, we'll be doing classes Monday to Friday only. Is that the?
No.
Oh, okay.
Yeah, we will have classes on Saturdays also, right?
Okay. So Saturday only, and Sundays off. Is it?
Yeah, most of the time Sundays will be off.
Okay. Okay.
And
Yeah.
if we
Kind
have
of
some questions remaining or something like that, so we will cover
catch
it
up.
on long sessions, okay? And on Sundays,
Uh,
okay?
okay. So, sir, we are starting the gastro next. You said right. So,
Yeah.
gastro. How long you're planning on doing
Yeah, I
gastro?
think the gastro questions are more,
Oh,
so
okay. Will take longer.
it will take about 10 to 12 days, okay?
Okay. So nearly
So
2 weeks.
what we
Okay.
are actually doing is we are trying to cover 20 to 25 questions each day, right?
Okay. Yeah.
And the schedule provided, they have sometimes question previously repeated questions, right?
Yeah. Yeah.
Like picking of each and every question idea is a bit difficult for us. So excuses for some questions that are not fitting on these topics. So the summary is that we are trying to cover each day 30 plus questions. Okay. Yesterday
Yeah.
we did 26 questions, I think, and three or four were excluded. So that's 30. So if you do with us along with our schedule, if you do each day 5 to 10 questions, so it will be easily covered in 90 to 100 days. Okay.
Okay. And then if we do go over the questions that you all have suggested, you're saying that that should be able to cover all the necessary theory we need to have for the exam, right?
Yeah, if you guys go through, like, if you just go through a single question of acid base, right, and do all the explanation very slowly and carefully, so those explanation will help you in acid base questions for even next 3 to 4 questions. Okay, so
Okay.
be careful and go in on a new, like on a new concept.
Yeah.
The first question, please go it thoroughly and slowly. And
Okay.
when such concepts repeat, it will be very easy for you and you will get it in your concepts. Okay.
Oh, okay,
So
sir.
I think UWorld is more than enough for studies. After that, we will do self assessments. You will do NBMEs, like these are exams, okay? So we'll take these exams from you, and when also the Dr. Ali is sharing with you the questions, right? The you had a test on Palmo, right?
Yes, sir, we had it.
So
How about like the explanations for those, like for the assessment
sorry,
test?
I didn't saw that exam,
Yeah.
and I would ask him if he have the explanation for those questions. I don't know where the questions were made or how the questions were made, but that Dr. Ali have done it.
Okay. Okay. No problem,
So
sir. Yeah. It
Yeah,
will be
so
good to know.
this way you are covering almost 300 250 to 300 questions weekly, right?
Yes, sir. Yeah, that's
Yeah,
true.
so hope so we will be covering all the U word.
Yeah.
Okay. Thank you guys.
And sir, after the GI, like, what's the next section
I
that's
think of
planned?
after the GI we will have endocrine, and after that we will have MSK, skin, then cardiology. Yeah, something like that.
Oh, okay, okay. All right. That sounds
Okay.
great.
So
All
after
right.
this we will be gastro and then endo. Okay.
Okay, okay. Wonderful. Thank you so much, sir. You have
Thank
a
you.
wonderful
Thanks
rest
a
of the
lot.
day. Bye bye.
Bye.
Take
Take
care.
care.
Take care.